Welcome to Endocast, the podcast where endodontics meets clarity. Hosted by Ahmed Shauki. Hi, Ahmed.
Hi, Francesca, and of course, by Francesca Shiruti. Today, we are diving into a deceptively simple question. How do we actually deliver irrigation into the root canal system? Because if there's one thing we have learned over the years, that's it. Shaping alone is not enough, even with the latest nickel titanium systems, even with the perfect instrumentation technique, we simply cannot eliminate all the microorganisms. That's a fact that we have to agree upon. And the anatomy is too complex. Lateral canal, isthmuses, irregularities, and biofilm uh, persist inside those difficult areas. That's why irrigation is not just an adjunct, it's a central and it is important really for the prognosis of our treatments.
Yeah, and it's fun that despite the technological advancement, we still are using a syringe and needle to deliver the irrigant to the root canal system. Then we can discuss about the shape of the needles and the materials and stuff, but that's what we use. And the main difference between general practitioners and specialists is in the fact that general practitioners in general only use sodium hypochlorite with a syringe, and specialists use more than one irrigant and they tend to activate the irrigants that they use.
Yes, inside the root canal, fluid dynamics are extremely limited and problematic. There is a consistent background that the literature gives us. Studying how can we clinically applicate theoretical concepts. We are dealing with a narrow, confined space where viscosity restricts the flow. On top of that, we often face closed-ended systems where vapor locks prevent the irrigant from reaching the apical area, not to mention the fluid exchange. And there is debris, dentin chips, organic tissues, biofilms, all of the accumulates and things inside the root canals that creates barriers. So even when we think we irrigate properly, in reality, large portions of the root canal are not flooded with our irrigant, which we need, really important in our treatment.
So basically, they tell us that we have to find a balance between the taper of the instruments that we are using, the diameter of our apical preparation, the irrigant that we choose at the time that we spend while doing this clinical step. For example, in this case, it's symptomatic because periodontitis, of course. You see that I open the access cavity and then I use files to remove the gutta percha. This step, I'm not using any irrigant because the file can just navigate inside the gutta percha as kind of soft, so I don't really need to lubricate them. But between every file, I will irrigate to remove all the debris that I'm creating with my shaping, as we saw in the last episode. What you see here is that my apical diameter is 60. So I did an apical plug with MTA. And you see that all the case leads to the resolution of the apical pathology.
Nowadays, we are moving towards conservative shaping protocol, or we can call it minimally invasive endodontics, to preserve the tooth structure, and that creates a paradox. The more conservative we are, the harder it becomes to deliver the irrigant effectively into the root canal because of the shapes and tapers. And that's where technique becomes critical. Let's consider needle penetration. In ideal conditions, a 27 gauge needle can reach about 3 millimeters from the apex in straight canals. A 30 gauge needle can perform slightly better in curved canals, but in conservative shaping, the needle often go beyond 4 millimeters from the apex. That means that the most critical area, the apical third, is precisely where irrigation becomes the least effective.
Yeah, and we know that increasing the apical preparation size can improve our penetration of the irrigant because a larger canal allows for a better flow, better exchange of irrigant, and more effective cleaning. But clinically speaking, this is not always feasible. We cannot achieve this all the time. And also, there are some studies that tell us that we have to go over the size of 25 if we want to make sure that our irrigant can arrive to the apical third and be effective. But some other studies tell us that there is no really significant difference between a preparation of 2506 and 3004 if we use a performing polypropylene cannula, for example. So it's controversial.
I agree, and so we need to follow strict clinical guidelines. Use thin needles, ideally 30 gauge needles. Prefer side vented designs, of course, because we need to have lateral shear stresses on the lateral walls. Stay 2 to 3 millimeters short of the working length. Never bind the needle inside the canal because we might have an accident by doing that, and never force the air again because that also leads an accident. There are simple rules, but they make a huge difference. If we want to improve the effectiveness of our irrigation, we can act on several parameters: time, concentration of the solution, volume, temperature is very important. Combination of irrigants, because we need to remove all the organic and inorganic parts, activation, shaping, type of the needle, and irrigation depth.
Yeah, but let's move to chemistry because not all irrigation is created equal. I mean, sodium hypochlorite remains the gold standard, and its effectiveness depends mainly on concentration, time, and renewal. And higher concentration, yes, they provide a faster tissue dissolution, a stronger antibacterial action, and deeper penetration into the dentinal tubules. But there's a nuance here. Increasing concentration does not necessarily improve the biofilm removal in complex anatomies, like isthmus or lateral canals. And it doesn't significantly affect the post operative pain either. So, again, it's not just about more is better, it's about how we manage the irrigant dynamically.
That's very important, and I agree with that. And one of the most important underestimated factors in irrigation is the refreshment, keeping flowing a refreshed solution, fresh solution. And arrogant loses effectiveness quickly once it reacts with organic tissue. So frequent replacement is essential. In fact, a lower concentration that is consequently and continuously refreshed can perform at a higher concentration left stagnant. And we have additional variables: temperature, as I said before, volume, irrigation depths, combination with other solutions like EDTA or surfactants to improve the penetration into the inaccessible areas. All of these influence the final outcome.
Yeah, and as you were saying, temperature is also important because heating sodium hypochlorite could enhance the chemical properties of the solution by increasing its reaction rate. And we can warm sodium hypochlorite either outside or inside the root canal. But it seems like intercanal heating is more effective than preheating sodium hypochlorite and then put it into the syringe and deliver it into the root canal system. And how can we clinically achieve this? Well, we can do it by activating the solution, for example, with ultrasonics or with laser devices.
A very interesting article by Butiukis traces some guidelines to irrigate effectively. At this point, we can summarize everything into 5 key principles of irrigation delivery. First, deliver the irrigant to the entire root canal system. That's logic, of course. Second, refresh it frequently because we need fresh reactions to perform its action. Third, generate shear stresses where it matters. We need side vented needles because it generates a lot of lateral stresses which can clear the root canal's wall laterally. Fourth, allow reverse flow for proper exchange. We need to eliminate anything that prevents any potential lack of exchange. Fifth, always prevent extrusion, avoid accidents, and these are not optional. These are not extravaganza. These are essential.
Yeah, and preventing extrusion is particularly important, and we will discuss maybe in another episode about this. But we need to be aware of the risk factors, such as large foramina, or root resorption, or an incorrect positioning of the needle, because improper irrigation is not just ineffective, it can be dangerous. And if there's one concept that really changes the game, it's activation.
Yes.
Because irrigation without movement is passive, and so it's limited. It cannot go where we really need it. So when we activate the irrigant, we increase shear stress, we improve the penetration, and we disrupt the biofilm more than just leaving the irrigant inside of the root canal and waiting for it to be effective.
And the numbers are really impressive because tissue dissolution can be up to 12 times faster with continuous agitation. We have several options: manual dynamic activation by vibrating the master cone, we have sonic systems, we have ultrasonic devices, pressure alternating systems, laser activation, other methods such as multisonic activation or specific devices like the pulp sucker. Each method has its own advantage, but they all share the same goal. We have to move and keep the irrigant moving inside the root canal effectively.
Yeah. And one aspect that maybe is interesting more for the patient than for ourselves is post-operative pain, because
Sure.
every technique can lead to some post-operative pain, some extrusion of sodium hypochlorite, but it seems that the application of agitation technique like laser activation, ultrasonic irrigation, gentle wave, or endovac can result in less or similar post-operative pain compared to syringe irrigation, with no significant difference among these activation methods. So maybe it's better to activate our irrigant even to try to reduce the post-operative pain for the patient.
You know what, Francesca? The problem is that we are missing a protocol. This is our problem. They say that volumes, application time, activation, etc., should be standardized, but no one has done it yet. In our retreatment book, the Style Italiano retreatment books, in the chapter by Riccardo Tonini and Francesca Cerruti, we try to clarify these steps. First of all, the irrigant used during the shaping phase only has the function to lubricate the files and remove the debris. This is the main function during the shaping.
Exactly. So the proper irrigation starts when we are ready to obturate. So
Exactly.
when we are done with our shaping, then we irrigate and we start counting how many milliliters of irrigant we are using. So in that
Yeah.
phase, we hypothesize like the minimum that we can do is like using almost 10 milliliters of sodium hypochlorite per root canal, delivered slowly, drop by drop. And each couple of milliliters, we activate, and then we refresh, and then we activate again. And so after this, we have taken care of the organic part. We can just wash out all the sodium hypochlorite with distilled water and use a couple of milliliters of EDTA per root canal, delivered in the same way, activated in the same way. And then we know that since EDTA opens the tubules, if we do one more passage of sodium hypochlorite after this, it's gonna go deeper. It's going to be more effective. So why not? We can do this again. And last, since we don't want any chemical interaction between our sealer and our irrigant, we wash everything away with some distilled water.
I think this is the real takeaway. So, what you have just said is a real protocol that we follow day to day in our practice, and it's really important. And, guys, please listen to that many times because it's really important. So, the real takeaway again is that irrigation is not a simple rinse, just flow some liquid inside the root canal. It is a controlled, dynamic, and highly technical process. It requires understanding of the fluid dynamics, chemistry, anatomy, and the technique that you are using, all working together. So you have to think about that thoroughly. Because in the end, irrigation is not a waste of time. It is really is the most important part of our treatment.
Yeah, but it's because it's the core of disinfection, and disinfection is the core of the endodontic success. And so, thank you everyone for listening. We hope you liked these indications about irrigation, and stay tuned for the next episode of Endocast.
Bye.
Bye bye.